further ado, I'd like to start the panel with Rick Haddock.
So I guess first of all, Mark, I'm not sure as being a payer that's sitting up here in front of a bunch of providers who have just had and partaking in some alcohol might be good for you. I don't know if it's going to be good for me. So I think we need to first get to know our audience. So I do have a question. For those of you that are in the audience, do you mind just by a show of hands showing me if you are a provider or you are affiliated with a provider? Okay, so it looks like about 50% or so. So of those that raised your hands, how many of you are currently participating in a value-based program where you as the provider or your office is under a value-based care program where you can earn a financial incentive for performance? How many of you are? All right, so I saw only 3, so we've got a ways to go. We got a lot of work ahead of us here, so appreciate the participation. So I'm going to try not to have a presentation that's death by PowerPoint. So I've got about eight or so slides, and I'll try to go through them fairly quickly. There we go. First and foremost, okay, come on, is it hitting it? The back one?
Let's see, I think it is this way. Go.
Yep. Is it the left or the right one?
It's the right.
Better pay attention.
I told you this was not going to be easy. Looks like it's frozen or something. If I hit this, won't work. If I hit the laptop. Yep, there we go. I'll just hit the laptop.
Okay.
This slide, this slide, all I wanted to do was to depict for you. These are some excerpts from both individuals as well as organizations, some current, not so current, as you can see with the Walter Cronkite, but the underlying theme is the same. And what that underlying theme is that I think we would all agree that the healthcare system, not only now, but over time, historically, has been a challenge for many of us that either are involved in the healthcare system or access the healthcare system. And in particular, when you start looking at the system as it is today, it's fragmented, inefficient, and both of those lead to higher cost. And so if you are currently not involved in value-based care because you think that value-based care is going to be a fad and is going to go away over several years like some of the other programs have, I think that Andy Slavitt with CMS said it best, which is that the shift from volume to value will not only endure, but it will accelerate. And I think you're seeing that today, both from government-sponsored plans as well as within the commercial space as well, from really all payers, whether they're large or small, there's a movement towards value-based care. Okay, there we go. So when we talk about some of the issues in value-based care, I know if I went out and I polled each and every one of you, I think everybody could come up with at least a dozen issues that are contributing factors to the current healthcare system today in the state that we're in. But I think one issue that continues to percolate to the top is around payment reform. And what you're seeing is a plethora of value-based care programs being developed again in all sectors that are trying to decrease the dependency of the provider community on a fee-for-service reimbursement and trying to create a model where we reward providers for the value in their outcomes as opposed to incentivizing and aligning incentives based on utilization and volume. And I think what you're going to see as part of the programs that we've implemented thus far, which is what today's presentation is about, that's exactly where we're headed, and we're going to continue to innovate with those types of programs. I thought this was just a fun slide because I think we've all seen a lot of different pay-for-performance and or value-based care programs that have come out there, and it literally is now the alphabet soup between the commercial payers as well as Medicare. And in fact, Medicare, CMS, actually had to develop a glossary of terms to account for all the acronyms that are associated with the programs that CMS administers. They've got to be able to find a way to track and define them because they're developing them so rapidly. And I think most of you who probably see some form of government-sponsored member, you're starting to see the growth of these and the dependencies that Medicare is trying to put out within the provider community on being able to participate in these value-based care programs. So I like to call this, it's a depiction of the progression of the payment model. So when you look to the far left, you've got fee-for-service. As you move to the right, down the continuum, you get the complexity of the model increases. the accountability, both from a provider perspective as well as a payer perspective, increases. But then the infrastructure that's needed to manage these particular value-based care models also increases. And as you move down the continuum, it becomes more complex for independent providers to be able to participate in those models, not only because of the willingness of the provider, but also because of the lack of infrastructure that's needed to manage the population underneath that particular model. And when you look at the far left, just from a BlueCross perspective, fee-for-service, we talked about the misaligned incentives in a fee-for-service structure. BlueCross, about 60% of our $33 billion in healthcare spend still falls under a fee-for-service payment model. When you look at the next 5 value-based care models, the remaining 40% of that $33 billion in healthcare spend falls under one of these different type of programs. And we talked about that we're going to continue to grow, and we're going to continue to invest in the models. What we've got to do is try to invest in those models that we know are going to lead to the outcome, the desired outcomes of all the stakeholders that are involved in the healthcare industry, which includes obviously our customers. For those of you who don't know, the majority of, I would say, many of us, many payers on the panel, myself and Aetna, not speaking on their behalf, but we've got a large percentage of our population where we have self-funded customers, and I think the previous panel touched on that. And basically, if you don't know what a self-funded customer is, that's where BlueCross and/or the payer, we function as a third-party administrator on their behalf. They are financially responsible for their claims. So when that is the case, you're starting to see even greater expectations on behalf of the customer, asking the payers to come up with models to help mitigate the cost trends that are currently occurring in healthcare today. When we talk about some of the value-based care programs that are out there, for some reason it's skipping multiple slides as well. So I had a different slide in here. There's a slide that is missing. All right. Well, there's a slide that was taken out. So I know I said it was included, but anyway, I want to talk a little bit about, before I get into the value-based care models where there is an indirect financial incentive for a provider to participate, I want to talk about what we're doing and what's available today for providers. So we started back in, I'm having to recall this from memory, we started back in 2005. We developed pay-for-performance programs, and those pay-for-performance programs were designed around physicians. I think we recognized over 10 years ago, we recognized the power of the pen of a physician. I mean, the physician not only can determine what services are going to be provided, but they can also determine where they're going to be provided. So the programs that we initially launched, and I heard somebody earlier talk about this, they actually asked the question, are you doing anything around site of service? And so coincidentally, 10 years ago, when we first developed our first value-based care programs, they were designed to incentivize physicians to, frankly, move business or redirect business to a freestanding facility. And the reason for that is it maximizes the member's benefit. I think we all know in most cases when a member goes to a hospital and they seek outpatient services, in particular outpatient surgery, outpatient lab, or outpatient imaging, it hits their outpatient co-share, which is typically higher than it would be if they get that same service performed in a freestanding setting. So the programs that we designed were around those site of service changes and incentivizing providers to move the business to a more cost-effective setting, therefore maximizing the member benefit. We did simultaneously develop some hospital-based metrics as well, but frankly, they were further down the curve as it relates to of importance, because we knew that, again, the power of the pen of the physician is, and that's where we are today when you start seeing the ACOs as well, was something that we needed to latch on to, and we need to continue to enhance the programs that were designed around the physician. But the hospital programs that we have, one of them in particular that's still in existence today is called the Texas Hospital Quality Initiative, and it's focused around pay-for-performance with hospitals in reducing hospital-acquired infections, which we all know are very costly, as well as create mortality as well. So we started those in 2005. Then we moved, I think it was 2009, we launched a program that was called Bridges to Excellence. Bridges to Excellence is a program that was developed by a company called HCI3. There's a total of 13 programs that are part of Bridges to Excellence, and it basically rewards providers who become recognized, one, and then two, for their outcomes. We, meaning Blue Cross, we currently support 4 different programs associated with the Bridges to Excellent model. In fact, I was just talking to Dr. Feynman about the IBD model that we're just now rolling out. But we support diabetes, cardiac, asthma, as well as, again, now the irritable bowel disease program as well. The next value-based care programs that we launched was our medical homes and our both an intensive model that focused on chronic patients, but also we had a full population, a broad population-based model that took into account the entire population, both the healthy as well as the chronic. That model at one time had about 80,000 members underneath it, had about 6 physician groups. We ended up sunsetting that in 2014 and transitioned them over to the ACO model. So the next value-based care program that we have are the ACOs, and that's really the bread and butter of what we're doing today. So we launched them in 2014, started off with about 20,000 members. We are now up to 22 ACOs geographically dispersed across the state. We've got about 600,000 of our Blue Cross members that are part of those ACOs. The ACOs are both designed for clinically integrated systems, but more importantly, they're designed for independent physicians and/or larger practice groups that meet the criteria to participate in an ACO. So how do independent physicians participate? Well, in 2015, Blue Cross, along with TMA, we developed a joint venture company called TMA Practice Edge. That company has been instrumental in our growth within the ACO community in that they were originally designed, and they still are, actively going out and aggregating independent and small group physicians who otherwise could not participate in an ACO by themselves unless they aligned with a clinically integrated system. They're aggregating those physicians within a certain geographic area together to allow them to participate in a population health value-based care program. So you'll see in just a minute, we're going to be migrating that to a version 2.0 moving forward as well.
Let me break in just for a minute. Y'all have these cards. If you have a question, please write it down, and we'll be picking them up. Oh, no,
All right. So the other indirect financial incentive programs that we have out there, we've got, obviously, you're starting to see the proliferation of narrow networks. You're seeing, I think, different levels of uptake depending upon the customer as it relates to, are they willing to sacrifice access for cost? I would say in many situations, you are seeing some, but in many situations, we're still seeing the request from a lot of, at least our large customers, they're wanting to continue with a broad-based approach. The majority of our business is on a PPO platform. The narrow networks that we've built, as you see here, are on an HMO platform. The Blue Premier is an HMO-based, commercially attractive network in the 4 major metropolitan areas. Blue Advantage, for those of you who are providers or affiliated with provider offices, that is our exchange-based HMO, has about 550,000 retail members in that particular network. Other programs I heard earlier, some of the employer panel, they were talking about transparency and trying to create an environment where members have greater access to being able to see performance on providers. Well, our Blue Compare, both for physicians and hospitals, we do that. It is on the website, and so that is one challenge, because I think most of us probably know that as a consumer of healthcare, very rarely do you go out and navigate websites to look for providers. Typically, it's either word of mouth, or you go through a third party, or you have a carrier who has developed a program that's designed to help members navigate their way through the complexity of the healthcare system. Or, most importantly, you listen to your other physician who gives you a referral to another physician, and most of the time you take that with a grain of salt and you go see that physician. So, one of the things that we're continuing to do is to try to find different ways to get transparency and information, both cost and quality, on providers out to the consumer as well as out to the provider, so that the provider can be educated in making those decisions. Excuse me. And I think most of us would agree that the healthcare sector in total, we are so far behind other industries as it relates to being able to provide transparency to consumers and allowing them to make an educated decision. Now, With that being said, our industry is really complex, and so it's hard to create that level of transparency in a way that's digestible for the consumer. So I think we've got a long way to go, but I think we're all making strides to get there. And the last program I want to talk about is it's a company called VaxCare that we're contracted with. VaxCare, what they do is they try to alleviate the burden for physicians. It's a voluntary program of having to manage and store and acquire immunizations and vaccines. So basically, they contract with us. We then, they bill us for those services, and they've got a technology tool where they will, upon request of the physician's office, they enter information into the computer, then they will deliver a certain amount of vaccines or immunizations. So it just takes the burden of the overhead away from the physician community. I know I'm running out of time, so I'm going to move on. When we talk about moving ahead, what's next, we're going to continue to innovate and optimize the programs that we currently have while also leveraging the infrastructures of some of the programs that we currently have. We talk about expanded pay for performance. One critical area that I think most of us, and for those of you who are employers in the room, still high ER utilization, a lot of ERs. A lot of ER utilization that's occurring out there. Even with the expansion of urgent care and after hours, we're still seeing members accessing the ER. But in addition, I talked about TMA Practice Edge. We're going to go to version 2.0. We've got to figure out another way to leverage the TMA Practice Edge model beyond just ACOs. Not all providers want to participate in an ACO, so we need to develop other pay-for-performance programs that and as you see here, that I called it bill once and deliver to many, but we've got to develop other programs that are scalable and repeatable, doing one-off type of arrangements with a particular provider group on pay for performance, and or developing programs that's specific to a particular specialty, but I can't scale it to all other providers within that specialty, creates a lot of administrative burden on behalf of, I'm going to speak on behalf of BlueCross, So we've got to continue to develop the programs that are going to meet the needs of the providers, because you have to meet the provider where they are. Not everybody wants to be in an ACO, so you've got to develop value-based care programs that the providers are willing to accept. And on that payment continuum, that means not jumping all the way to global capitation or even somewhere in there between. You've got to start with simple programs like Bridges to Excellence, which doesn't require a lot of infrastructure on behalf of the provider community. So with that, thank you very much.